Good morning, good afternoon, or good evening, wherever you are. It is my pleasure and privilege to moderate our journal club today. My name is Abdel Rahman Nimeri. I'm connecting from my home in Charlotte, North Carolina. And today we're going to discuss the Ifso position statement on the role of EGD before and after bariatric surgery. We have a fantastic speaker and panelists that I would like to present first, and then we'll have Professor Wendy Brown give us a presentation, and then we'll have a discussion for the rest of the hour. So the speaker today is Professor Wendy Brown from Melbourne, Australia. She's the chair of the Department of Surgery and director of CORE and the clinical lead for the Bariatric Surgery Registry at the Department of Epidemiology and Preventive Medicine at the School of Public Health and Preventive Medicine at Monash University in Australia. Welcome, Wendy.
Thank you.
Sure. And we also have with us as panelists Professor Ricardo Cohen from Sao Paulo, Brazil. Ricardo was the Congress President of the Ifso Congress in 2016, past President of the Brazilian Society of Bariatric Surgery and the Director for Center for Obesity and Diabetes in Sao Paulo, Brazil. Welcome, Ricardo.
Hi all. Good morning, good evening, good afternoon.
We also have with us Rachel Moore from New Orleans, Louisiana, here in the U.S. Rachel is a bariatric surgeon at Moore Metabolics, rather. She's the founding president of the Louisiana chapter of ASMBS and the ASMBS state chapter, committee chair, and an executive council member at ASMBS. Welcome, Rachel. And we also have with us Mahawar. Kamal is consultant general bariatric surgeon at the Sunderland Royal Hospital and a visiting professor at the University of Sunderland. He's an associate editor of both obesity surgery and clinical obesity, and the chair of the patient safety committee at BOMS, and an author of The Ethical Doctor and Fight with Fat. Welcome, Kamal.
Thank you, Rahman. Thank you.
And last but not least, we have Professor Haitham Fawal from Beirut, Lebanon. He's the past president of the Pan-Arab Society for Metabolic and Bariatric Surgery, chair of the Ifso MENA chapter corporate and finance committees, and program director for the fellowship program at their hospital. Welcome, Haitham. So without further ado, I would like to ask the listeners to please send us your questions through the chat box. I'll be monitoring these questions, and we'll plan to have Wendy give us a 18 to 20 minute presentation about the substance of the Ifso position statement, and then we'll have a discussion about questions I might have or questions you might have. So please post as many questions as you can. So without further ado, I'm looking forward to the presentation from Professor Wendy Brown. Wendy, please.
Thank you very much, Dr. Nimeri, and thank you very much to the Ifso for this kind invitation. It's my real pleasure tonight to present to you the findings from the Ifso position statement on endoscopy and bariatric surgery. Up front, I'd like to acknowledge the task force that was established by the Ifso Executive Board that worked very hard with me on this position statement, and also the scientific committees of Ifso and the Executive Board who have also approved the statement before publication. I'd like to thank them very much for their hard work and for making this position statement possible. These are my disclosures. So endoscopy, or more properly esophago-Gastro-Duodenoscopy, is a test that you'll all be aware of, but just so that we're on the same page, it's a test where we pass a optical viewing tube down through the mouth into the esophagus, down to the stomach and the duodenum, and we're able to visually inspect the lumen. It also enables us to take biopsies of both normal mucosa and abnormal mucosas. And as you know, we would use this usually for diagnosis of upper GI pathology. We use it for screening for early disease and for early intervention. And we can also use it for surveillance. And increasingly, we're using endoscopy for intervention. The typical indications for EGD, or esophago-Gastro-Duodenoscopy, are probably best summarised by the American College of Physicians. So typically we'll do it when a patient presents with what we call a heartburn with alarm symptoms, which include dysphagia, bleeding, vomiting, weight loss and anemia. For people who have persistent GERD symptoms despite 4 to 8 weeks of twice daily PPI use. For patients with severe erosive esophagitis after a 2-month course of proton pump inhibitor to confirm healing. It's indicated to assess healing and to rule out Barrett's esophagus, and to evaluate a patient with a history of esophageal stricture with recurrent dysphagia symptoms. It should also be used in patients with an established diagnosis of Barrett's esophagus if there's no dysplasia, and the surveillance interval is recommended not to exceed 3 to 5 years, and we will come back to this. And particularly EGD is indicated in men aged greater than 50 with chronic GERD symptoms and additional risk factors for esophageal adenocarcinoma, meaning mainly nocturnal GERD, hiatal hernia, increased body mass index, and intra-abdominal fat distribution being a central distribution, as well as tobacco use. So these are the common indications for EGD. There are probably more, but these are the main summary by the American College of Physicians. If we think about using EGD as a screening tool, then again, there's several different guidelines out there, but most of them will indicate that screening EGD should not be routinely recommended for people just with heartburn. It needs under the age of 50 or 60, depending which ones you read, normally the symptom of heartburn, which is very common in most populations, with about 60 to 80% of people experiencing that symptom relatively regularly. So it shouldn't be done for heartburn in isolation. It usually has to be in combination with another one of those alarm symptoms that I mentioned before. In terms of Barrett's, when we think about screening for Barrett's, the general guidelines will be when you found Barrett's on a scope that's done for whatever reason, if there's no dysplasia and it's a low risk procedure with a maximal length of less than 3 centimetres, you should repeat the endoscopy at 3 to 5 years. But if the Barrett's length is longer, putting it at a higher risk, then you should repeat that endoscopy at 2 to 3 years. If it's indefinite for dysplasia, then you need to repeat the biopsy in 6 months, treat with acid suppression and repeat the scope. Low-grade dysplasia and high-grade dysplasia I won't go into discussion today because this is probably outside the scope of this talk, but obviously these are people that then go into a much more frequent either screening surveillance program or treatment regime. So these are the broad indications for EGD in most communities, and I think when we looked through what the different guidelines were in different countries, they were fairly consistent. Some said the cutoff score for when you should start thinking about heartburn as being a symptom that you might want to start looking at screening was 50, some said 60, but overall they are fairly consistent. So the question became, should metabolic surgery change these indications? So why might it change the indications for screening or diagnosis? And I guess partly it could be because we know obesity is a risk factor for upper GI pathology. As I mentioned before, particularly in men, it's the #1 risk factor for esophago-gastric cancer, particularly adenocarcinoma. It's also a risk factor for Barrett's esophagus, for GERD itself, and also for hiatal hernia. It's also possible that if we did do a preoperative EGD, that we could detect abnormalities that would change or modify our bariatric metabolic procedure choice. So if we found someone, for example, that unexpectedly had an esophageal adenocarcinoma, we would not wish to proceed with surgery, obviously. Similarly, we may find varices, which would potentially be a contraindication, or we might find something like Helicobacter or peptic ulcer disease that we may wish to treat prior to doing our surgery, depending on what the access to the stomach afterwards may be. Similarly, when we think about surveillance, metabolic surgery may be a risk factor in itself for upper GI pathology. And that's because some of the side effects of metabolic surgery include GERD, bile reflux, and that can lead to things such as Barrett's esophagus and stomal cancer in theory. It hasn't been proven, but it remains a theoretical risk on the background of our previous experience with ulcer surgery and animal studies. It's also possible that the altered anatomy that we have with our metabolic procedures, particularly the bypass procedures, make part of the upper GI tract inaccessible following our surgery and therefore difficult to assess if we want to continue to screen for something such as gastric cancer in a high-risk population, such as the Asian populations. And similarly, some of the procedures we perform have complications. In fact, they all do, and we know that. And it may be that we need to change our surveillance regime on the basis of that to see if we can detect early complications of metabolic surgery. But there's very little literature to inform this, and in a situation where we have very little high-level evidence is when the profession seeks guidance. And Ifso have come up with a very clear position statement on position statements that was developed in the time when Kelvin Heger was our president. Kelvin determined that it would be important that if we have a scenario where we don't have clear guidance, where isn't clear what we should do, that Ifso should strive to look at the literature as best we could that was available at the time and come up with some practical, pragmatic guidelines that can help to guide practice so that we can ensure patient safety as best as possible while we're waiting for evidence to emerge. So the position statement on position statements is a clinical problem is identified. The executive board then appoints a task force to review the problem. A systematic review is undertaken and guidance is developed on the basis of that systematic review. The task force then passes on their guidance to the scientific committee for review, for comment, and for approval. And once that process has been confirmed, the final endorsement occurs at the level of the executive board. Once the executive board of Ifso is satisfied, then the position statement will be published. However, the nature of these position statements are that they need to be reviewed every 2 years or if new evidence emerges. So in the instance where the question came up is how should we be using EGD before and after metabolic surgery, we first of all had a task force appointed, and the members of that task force are listed in the obesity surgery article that you've been provided with. And again, I would like to thank them very much. They come from all the Ifso chapters, and all of them worked extremely hard on this. Our systematic review was primarily undertaken by one of our research fellows, Jasmine Yahare, and one of my bariatric fellows, George Bellaris, and they went through nearly 19,000 records that they identified through a database search. From this, just over 10,000 titles and abstracts were screened, and 217 full text records were finally assessed for eligibility. In the end, from those, 63 records were included and 30 records were identified to include management where it was changed due to the gastroscopy results, and 11 records were identified where the post-operative gastroscopy was performed. The reasons why things were excluded are listed down the side here. It needs to be noted that these are mainly retrospective studies, and there is minimal high-quality data upon which we could base our recommendations. Therefore, the overall risk of bias is noted to be high in this strategy. But that's exactly why we need a position statement, because we need some guidance, some pragmatic guidance that hopefully helps to guide us to protect our patients while we await some higher level evidence. So if we look firstly at the role of preoperative EGD before metabolic surgery, we identified 63 studies involving 22,495 patients where there was one or more abnormal finding, and the mean percentage of abnormal findings ranged in each study from 4.6 to 89.7%, so a very broad range. Gastritis and hiatal hernia were the most common abnormal finding. If we tried to correlate the preoperative EGD and preoperative symptoms, so saying should we only screen patients who have preoperative symptoms such as heartburn or those alarm symptoms that I listed before, there were only 11 studies that considered the presence or absence of these upper GI symptoms. This involved 7,000 patients. The mean percentage of symptomatic patients in these studies again was a very broad range of 12.1 to nearly 60%, with a mean of around 32%. In the symptomatic population, a mean of 16% of patients had at least one abnormal finding. In the asymptomatic populations, importantly, a mean of 25% of patients had at least one abnormal finding. So this suggests that potentially we cannot rely on people's preoperative symptoms to inform whether or not we would find an abnormal finding. But does that really matter if it doesn't change our management? There were 30 studies that looked at management changes based on the preoperative EGD, with a total of 15,000 patients. Around 2,500 patients, or 16.8% of these patients, which is a combination of what we call Group 3 and Group 4, had a finding that changed their surgical management. In Group 3, the abnormal findings led to a change or delay in surgical management, and in Group 4, there was an absolute contraindication to bariatric surgery, and these were mainly either cancers or varices. There were only 2 studies where management was changed and reported upper GI symptoms, and in those studies, 68% of the patients whose management were changed and 78% of patients whose management were changed did have upper GI symptoms. So it's a very difficult area to really completely understand. If we routinely screen all patients, the studies ranges from somewhere between 4% to 89% of patients will have some abnormal finding. Symptoms are very hard to go on to see whether or not an abnormal finding will be found. But if there's a significant finding that does change your management, it is more likely, so these people that fall into Group 3 or Group 4, it is more likely that you will have an upper GI symptom. If we then focused on EGD following bariatric surgery, and we found 11 studies that compared the findings before and after surgery. So there was just over 1,000 patients in those studies. In the gastric band studies, there was only 44 patients enrolled in the 2 studies. One study found a nearly 40% incidence of proximal pouch dilatation at 6 months follow-up. And importantly, in all these patients, the ones that had esophagitis and the ones that had the pouch dilatation, all the patients with pathology had symptoms. So very small numbers, but the numbers suggest that following a gastric band, if you've got a significant pathology that's found on a gastroscope, you typically have a symptom. In the Roux-en-Y based studies, there was a reduction in gastritis in 2 studies, but another study had an increase in esophagitis and another study had a decrease in esophagitis. So very mixed findings in differences in findings in the post-operative studies. Complications of Roux-en-Y gastric bypass were also, unexpected complications of Roux-en-Y gastric bypass were also reported in 3 studies. But again, importantly with the Roux-en-Y gastric bypass, significant findings such as esophagitis, gastritis, and the major sort of things such as ulcer and fistulae, patients with pathology tended to have symptoms. So with gastric bands and gastric bypasses after surgery, new pathology typically seems to be correlated with patients' symptoms in the studies that we've looked at, but noting that they are very small numbers. Sleeve gastrectomy. One study found rates of esophagitis were increased following bariatric surgery, with 53% de novo, of this being de novo esophagitis. However, another study found 19% of patients had improved esophagitis severity. There were 3 studies at the time that we did this systematic review, and they reported de novo incidence of Barrett's esophagus at 15%, 17.2%, and 18.8% at their follow-up time points. Importantly, patients with Barrett's esophagus had poor symptom correlation. So you couldn't rely on the patient presenting saying that they had any particular symptoms such as heartburn, dyspepsia, or reflux to correlate with the Barrett's esophagus. There has been other studies published since, and there's been a very nice meta-analysis published since we did our systematic review, suggesting the rates of Barrett's esophagus are more like 8%. And we're actually currently finishing off our position statement on Barrett's esophagus following metabolic surgery. It's now at the stage where it's going to go to the executive board, and I'm very hopeful that we'll be able to have that published in the weeks to come. So based on these data, the recommendations from the Ifso position statement on EGD before and after bariatric surgery were that EGD should be considered for all patients with upper GI symptoms who are planning to undergo a bariatric procedure due to the frequency of pathology that may alter management. Noting that the mean of 55% of all comers have at least one upper GI symptom, and that symptomatic patients have a 16% chance of significant pathology. We also recommended that EGD be considered for patients without upper GI symptoms who are planning to undergo a bariatric procedure due to the 25.3% chance of an unexpected finding that may alter management or contraindicate surgery. So essentially, we were recommending that EGD should be considered for anyone, symptomatic or asymptomatic, who is considering a metabolic procedure. We went on to recommend that EGD should routinely be considered in populations where the community incidence of significant gastric and esophageal pathology is high, particularly when that procedure will lead to part of the stomach being accessible. So this is particularly in Asian populations where the community incidence of gastric cancer and esophago-gastric cancer is very high. If those patients are to undergo a Roux-en-Y gastric bypass or OAGB, and you may note that I didn't mention OAGB too much tonight because there really isn't much information out there at the moment, and so therefore we are relating this mainly back to the bypass procedures. But in these high-risk populations, we are recommending that patients undergo EGD before and after surgery at regular intervals. We also recommended that EGD be undertaken routinely for all patients after bariatric surgery at 1 year, and then every 2 to 3 years for patients who have undergone laparoscopic sleeve gastrectomy, and we included OAGB because of the risk of bile reflux to enable early detection of Barrett's esophagus or upper GI malignancy until more data is available to confirm the incidence of these cancers in practice. So we have a signal from some studies that there is de novo Barrett's esophagus following laparoscopic sleeve gastrectomy, and we have a concern about OAGB because of the previous experience with the Bill Roth procedures and the one case report that we have of an esophageal adenocarcinoma. And until more data is available, it was considered prudent by the Ifso that patients need to be reviewed relatively regularly along that higher risk, so the long length of Barrett's type regime rather than the short length of Barrett's regime, because this is conservative and safe. EGD we then considered should be performed following after, we then recommended that EGD should be performed following AGB and Roux-en-Y gastric bypass on the basis of upper GI symptoms, because all the published data, admittedly very low numbers, do suggest that there's high symptom correlation for pathology. So I've run you through quite a long and complicated position statement tonight fairly quickly so that we have time for discussion. I think it's important to note that EGD is an important diagnostic test, and we're very clear on how we use it in our routine upper GI practice. But we currently, unfortunately, don't have high-level evidence to guide practice on how EGD and these guidelines should be best applied in metabolic and bariatric surgery. The position statement is intended to provide clinical guidance where there's limited evidence available, and it's not a substitution for high-level evidence. We desperately need high-level evidence addressing this issue, and a large prospective cohort study, perhaps using a registry, or potentially a randomized controlled trial, although I'm not exactly sure how that would be powered or achievable. I think it's more likely we'll get good data from large prospective cohort studies. We really need information from those studies to specifically address this issue, and these guidelines will be reviewed in 2 years' time. I'd like to acknowledge again the Task Force for EGD and Bariatric and Metabolic Surgery, Kelvin Higa, Scott Shakura, Guilherme Campos, Yasmin Yahori, George Balalas, Lillian Cow, Jacques Impens, Almina Ramos, Miguel Herrera, and Ahmad Bashir. I'd also like to acknowledge the members of the Ifso Scientific Committee and the Executive Board for their kind input, and always Manuela, who keeps us on track and helps us in so many immeasurable ways. So thank you once again for this opportunity to present tonight, and I'll hand back now to Dr. Namiri for questions and discussion.
You're mute, Nimeri.
So thank you, Wendy, for your presentation, which is excellent. And I want to echo and second your thanks to Manuela, who's not only running this journal club for us, but does a lot of work to keep us in check. So first question to Ricardo. So the position statement, Ricardo, says that upper endoscopy should be considered for all patients prior to bariatric surgery, especially if they have symptoms. Now, my question is, should we do this for all procedures, given that in the studies that they reviewed, the most common two findings were gastritis, a hiatal hernia, or esophagitis? So if someone is undergoing Roux-en-Y gastric bypass, what difference does it make?
That's a good question, Mary. As Wendy pointed, and I reviewed that because I'm in the scientific committee, we don't have any robust data to answer your question in a straightforward fashion. So what I think is that if I do a gastric bypass in asymptomatic patients and we find a hiatal hernia during the operation, we're going to fix the crura and keep on doing the gastric bypass. In asymptomatic patients, and what I think we should think on an age cutoff, if patients are asymptomatic and they are below 40 years old, probably the findings won't be very, we won't have any positive finding. So what I think is we still have no answer. We need large prospective trials. I don't have any clue how to design an RCT based on endoscopy, yes or no. I think there's no way to power that because we actually have no data at all. But what we do, actually, this is a personal view and based on the position statement that Wendy just presented. We do endoscopy in all patients, regardless of procedure. My center is biased to gastric bypass because of several reasons. We do in asymptomatic patients if they're 40 or older, because we don't have any evidence that is cost effective and the findings will be positive that may change our practice.
So your approach is selective endoscopy for patients who are 40 years or older if they're asymptomatic.
Yeah.
Okay. So thank you. So next question to Rachel Moore. First of all, thank you, Rachel, for joining us. I wanted to ask you, since you practice just like me in the U.S., what's your practice and how do you get insurance to cover bariatric surgery? I know it's a particular issue in the U.S., but we have many Ifso members who are U.S. surgeons. What do you do when someone does not have symptoms in the U.S. and you want to do exactly what Ricardo does? Like, how do you get insurance to cover it?
Smart question. And I, unfortunately, as a Louisianian, am a representative of one of the worst places in the world with a high prevalence of obesity and a low access to treatment. And so this is something that I would love to just do medicine and not ever talk to anybody about money. But this is something that comes up with every single patient I see. So the answer is that philosophically, I think that endoscopy on asymptomatic patients it's quick, it's relatively easy, exceedingly low risk. And as this position papers showed us, sometimes you find something that you didn't know was there. But you're absolutely correct that without a diagnosis, I'm not going to be able to get that covered by the insurance.
So how would you say if someone just said, you know what, it's not a big deal, just add GERD to the diagnosis and do the endoscopy, it's justified based on this position statement?
Well, in our patient population with obesity, a vast majority of them do have occasional heartburn. In fact, upon questioning, most of them will have, post-operative bariatric patients often experience occasional dysphagia. Dysphagia is something that I use on a post-op patient sometimes. And upon questioning, a lot of patients with obesity have experienced heartburn from time to time. But in a truly asymptomatic patient, I don't have the luxury of doing a preoperative endoscopy.
So what's your practice right now at More Metabolics? What do you do in regards to preoperative screening with upper endoscopy for bariatric surgery?
I do them. I'm a big believer in it. As I said previously, I think it's a low risk procedure. I tell, with patient-facing language, I tell the patients it's my actual eyes on your esophagus and stomach, and I get a lot of information. We prefer not to be surprised in the operating room. There's very little that we could discover that I can't handle, but I would prefer to get the opportunity to make a plan ahead of time rather than discover things in surgery. And so in a patient where I can find a diagnosis, I prefer to do preoperative endoscopy.
Thank you. Kamal, I would like to ask you about one anastomosis gastric bypass. Wendy just told us that they've looked at the entire body of literature and did not find much. So my question is for you is, what's your practice in Sunderland in regards to preoperative endoscopy in general, but in particular, since your group does a significant number of one anastomosis gastric bypass, what is your practice, and does the NHS have any red tape like US insurance companies when it comes to covering these preoperative endoscopies for asymptomatic patients?
So thank you, Abdulrahman. So first of all, congratulations to Wendy for an excellent position statement paper and the talk. Coming to your first question, we in Sunderland do routine preoperative endoscopy for all our patients, and we have been doing it for over a decade. So that's our routine practice, largely because we are mainly a bypass unit. So we like to know before we bypass the stomach, and that's been paid on the NHS. And I think in terms of funding, NHS gives you a lot of leeway with regards to clinical management. And if clinicians decide to do it, then I personally don't find too many obstacles in my way. So that's the first question. The second question, which I thought you would come to, is the one anastomosis gastric bypass. And I have found, and that was just researched, for 2 hours this morning, Abdulrahman, a paper by Liagre et al. That I have open in front of me, and I'm going to read out some lines from there. They have been able to do 46 patients agreed to have endoscopy at 8 years, and the authors say that endoscopy at 8 years, they found esophagitis in 6.5% of patients and no Barrett's esophagus. I then found subsequently another paper from Carbejo et al., and they are saying that almost 80% of patients did not accept to have endoscopy at 5 years, but the ones who did, they had mild to moderate pouch gastritis in 8% and Helicobacter pylori in 3%, but there were no endoscopic or histological changes. So what I'm saying is that I think the data is less, and Wendy is right about that, but data is not non-existent. And I know from my personal communication with Jean-Marc Chevalier many years ago, he published a few things on endoscopic surveillance after one anastomosis gastric bypass as well. I couldn't find the paper this morning when I looked for it, but I remember from emailing him almost a decade and plus ago that he was doing some work on that, and that's out there as well. So what I'm saying is that data is less but not non-existent. On the back of that, sorry.
Sorry, Kamal, just to clarify, the data that we looked at was where there was data before and after. So there was no studies that showed what their preoperative EGD was compared to their postoperative EGD.
Yes. I think that would be a fair criticism, that the comparative studies where you have done endoscopies before the surgery as well as after the surgery, they are not there. So that is the first thing, that with regards to OEGB, I think the data is lacking, but even the proof of concept for endoscopy, the bile reflux and the cancer analogy, that keeps coming back. So I will try and address that once again. 1 or 2 cancers in a high-risk cohort where you are projected to have 1 in 150 patients developing either gastric or esophageal cancer around the world is nothing. We should be looking as scientists at the total prevalence or incidence of these diseases as opposed to the expected incidence or prevalence. And I think what we've seen so far, to the best of my knowledge, is 2 cancers following one anastomosis gastric bypass. And let's not forget, we have a historical model of these operations, which is called Mason's loop gastric bypass, of which we performed on 10,000 in just US alone. And of those patients, only 1 patient had cancer in the pouch. So I think the proof of concept for these tests is also lacking. So I agree with most of the recommendations, but the recommendation number 4 for routine surveillance after sleeve as well as OAGB, I disagree with both. And with sleeve, I have my own reasoning, but I think you wouldn't give me time for that. So I'll leave that there for now.
Thank you, Kamal, for bringing some interesting points. I'll make a comment real quick, and then we'll move to a question for Haitham. I think with the same analogy, then your rationale for doing preoperative endoscopy before Roux-en-Y gastric bypass is not justified, because you're going to bypass the stomach, but the literature shows that you rarely find peptic ulcer disease, and they rarely develop cancer in the remnant stomach. So next question, because we also have questions from the attendees that I want to get to. So Haitham, tell us about preoperative endoscopy in your practice in Lebanon, and also tell us about, in particular, sleeve gastrectomy. Do you think should be done in everyone, especially because Wendy told us that Barrett's esophagus could be asymptomatic. She told us that the risk of de novo reflux after sleeve gastrectomy is high as 59%. And she told us that most of the findings are hiatal hernia, esophagitis, which are important things to consider. And the fact that many patients in Lebanon are cash pay, does that make a difference in selecting what to do?
Okay, so for my practice, I did only pre-op endoscopy for symptomatic patients. You know, Abdurrahman, there is a large MBSA data published like 2 years ago showing the cost effectiveness of doing pre-op endoscopy on all patients. It was not in favor of doing endoscopy. So it will take really a long time to convince insurance companies to do the pre-op endoscopy. And this is something that we should look at Ifso, because putting in our position statement, it should be considered may put us under liability as surgeons later. Because if we did like sleeve gastrectomy now or whatever, why one anastomosis, and patients comes afterwards after 5 years and he said, you did not do an endoscopy for me, and this should be considered, and patients presented with Barrett's will end up in courts. So I think the sentence of ASMBS, which is may be considered or level D evidence, makes more sense, I believe. So this is my first point. Second, for the sleeve gastrectomy, yes, I believe even if asymptomatic, I believe in post-op surveillance, yes, but still I would go for only symptomatic patients for a routine endoscopy.
Thank you, Haitham. You bring a very important point about the cost effectiveness. Even though upper endoscopy is a simple and safe procedure, but it comes at a significant cost. In the US, the deductible you have to pay for having an upper endoscopy is not insignificant. So going back to Wendy, there's a question from Humberto Jimenez, and I want to also add a question to his for you. His question is, what is the safe timing for endoscopy before Roux-en-Y gastric bypass? And I want to ask you in particular about the fact that the American Society of Gastroenterology recommends that if a surgeon operates or a gastroenterologist in a non-endemic area for H. pylori, my question is about H. pylori and reflux. We know that there's an inverse relationship between H. pylori, reflux, and Barrett's. And their recommendation that if you live in an area like the US or Australia, where H. pylori, I suspect, is not very endemic, if you do an endoscopy and the patient has no dyspepsia, you should not biopsy for H. pylori, and you should not treat it. So if you can comment about your practice and what your thoughts about this. When you do endoscopy, and when is it safe to do endoscopy before surgery?
So I live in a very blessed country where we can decide what we want to do for our patients, and it gets paid for, either the government or our insurers. And the cost of an upper GI endoscopy, if someone has to pay for it themselves, is around $300-400 Australian dollars, which is, I don't know, 250 US dollars. It's not a very big out of pocket for patients. So, you know, we're quite blessed that we have that kind of access to care. But if I'm honest, I only scope people who have symptoms. That has been my practice because I've felt that the risk to benefit ratio, the cost, but also the inconvenience to the patient for having to come in and have another procedure. But actually, since doing the systematic review, I have changed my practice a little. I have started to screen for reflux in my sleeve patients, partly just so that I can fully document what changes were there beforehand, so that I know what changes have happened afterwards. I am concerned about Barrett's following sleeve, and also I do want anastomosis gastric bypasses. I think it's a great procedure, but I'm also an upper GI cancer surgeon and I worry about that. So I'm also scoping them beforehand. And I guess we're gathering the data pre and post so that we can see what the changes are. But with that sort of conservative background, I have been doing an index scope at a year and then every 2 to 3 years since I did this position statement. I think in the past I've been a bit more like Rachel. I feel like I can cope with most things, you know, when you get in there, but it is nice to have a roadmap. And I think increasingly, I think it's important that if we can document what's there before, because we know obesity is a major risk factor for all of these conditions like hiatal hernia, like reflux, like cancer. If we can find what's there before, then it just helps us down the track to know what cause or what effect the metabolic surgery may have had, good or bad, on that condition.
Sure.
So I'm probably, I don't know about Helicobacter. I guess our practice here still is, I think it's pretty endemic in Australia. We've got a very big Asian population, so maybe that's why we tend to treat Helicobacter when we find it, because it's still recognised as a primary carcinogen. And that's on that basis that we're treating it.
And do you treat it even if the patient was asymptomatic?
Yeah.
Okay.
Yeah, and I routinely do biopsies of because I do a lot of upper GI scopes for other reasons, and I'd always take a biopsy of the distal stomach, proximal stomach, and distal esophagus, and plus or minus duodenum. And if I find Helicobacter, even if it's unexpected, we eradicate.
Jack Himpins has a question for Ricardo Cohen. He says, this means patients under 40 experiencing problems after Roux-en-Y gastric bypass won't have a baseline endoscopy data to compare to. Do you do HP testing in any other way? And I will add to this question, when you do an endoscopy for a patient who's asymptomatic, Ricardo, do you check for H. pylori? And if you find it, patient is asymptomatic, do you treat for it?
Yeah, answering your question first, yes, we do treat them. And second, to Jacques, we do test routinely H. pylori, the breath testing. And this is covered by insurance here, and the test is not expensive. Patients don't have insurance, they pay out of their pocket. So we test for H. pylori and we treat them even if they are asymptomatic. But if you look at the findings, Jacques, in patients that are asymptomatic and are younger, it's 0, 0, 0 something. So I don't believe that's useful for our it won't change our procedure. So, but we test H. pylori and treat them even if they're asymptomatic.
Thank you, Ricardo. So, Rachel Moore, you can take the second question from Humberto Jimenez. When is it safe to do upper endoscopy prior to Roux-en-Y gastric bypass? And I'll add to it, why not just do an intraoperative endoscopy before you start the case? If I'm an insurance carrier, I'll tell you, listen, patient is in the OR, they don't have symptoms, just take a scope at the beginning, take a look at their stomach, take a look at the duodenum, and then you can start.
So that's only an insurance company would ask that question, because surgeons know. The insufflation is going to bug me when I'm trying to do my surgery, right? So So that's why that's not my, I of course can do a pre-procedure endoscopy on the table and try to, clamp things off and so forth. But that's inconvenient and not my preference. Please repeat the first question.
When is the safe timing for endoscopy prior to Roux-en-Y bypass?
I would be comfortable doing that at any point. I mean, this is just me looking. I'm not doing a procedure. So, any time. I guess I don't understand whether his question is whether pathology could develop in between my endoscopy and the procedure itself if the time is too long. But I generally do these within a month of the operation. I hope that answers his question.
Thank you. Well, Humberto Jimenez, if that does not answer your question, please type in and let us know. So Haitham Fawal, there is a question from Khalid Al-Shahrani. He asks, in particular, as per the recommendations to do endoscopy routinely prior to bariatric surgery in some high-risk populations, I can think of the country of Oman in the Gulf region. Are there any reported cases of post-bariatric surgery gastric cancer in the remnant stomach in high-risk population? He mentioned Asians, but I can also tell you the country of Oman has quite a high risk of gastric cancer. Haitham, we lost you. Are you still there?
I'm back.
Okay, good. Did you hear the question?
No, please.
Yeah, the question is, in a high-risk population, like, is there any reported cases of gastric cancer in the remnant of the stomach?
I did not get you.
Let's do this. Let me move the question to Kamal, and I'll ask you a different question. Kamal, you heard the question?
Could you repeat again, sir? It's not clear. In a high-risk population, what exactly are we saying?
So like you mentioned earlier, that the reason you do an upper endoscopy in gastric bypass patients is to know before you bypass.
Yeah, correct.
Are you aware of any literature of gastric cancer in the remnant stomach in Roux-en-Y gastric bypass, especially in high-risk populations?
So I'm not aware of much literature on that topic either. We anecdotally believe that Roux-en-Y gastric bypass reduces the incidence of gastric cancer, and we also know from data that when these cancers do happen in the bypass stomach, then they present at a later stage. So that's all I know in terms of academics about this. How do you diagnose them? Of course, the diagnosis will be delayed in terms of because the access is not there. That is one of the problems with gastric bypass procedures, both RYGB and OAGB.
Sure. Thank you, Kamal.
There is one article published by George Al-Haj like 3 years ago, and they studied the gastric cancer development post-gastric bypass, and they found that the gastric cancer was developed in 65 or 70% in the remnant stomach in Roux-en-Y gastric bypass.
Thank you, Haitham. I can make 2 comments. There is a large systematic review that looked at this, and the incidence of gastric cancer in general after one anastomosis, sleeve gastrectomy, and Roux-en-Y is very, very low. But I will say that countries like Oman and Japan do not do Roux-en-Y gastric bypass. They do either a sleeve gastrectomy or they do procedures where they do a sleeve and an intestinal bypass like DJB. So next question back to Wendy. From Dr. Ahmed Bashir, one of the co-authors in this position statement. How would you treat H. pylori first patients undergoing sleeve gastrectomy if asymptomatic, given the recent H. pylori being protective against Barrett's esophagus in the EAC? Meaning, he means if you treat H. pylori patients who are undergoing sleeve gastrectomy and they're asymptomatic, because there's an inverse relationship with the presence of H. pylori and reflux and Barrett's, you're putting them at a worse position, actually.
Well, we don't. Yeah, I guess we don't know that. That's been a theory for a long time. I mean, it's that the theory about the urease being produced by the Helicobacter, that it causes a sort of alkaline shield at the top of the stomach. And then you've got to balance it against the fact that it's a gastric carcinogen. So I don't know, and I don't know in practice what the answer is, but I do know it causes ulcers, and I do know it causes gastric cancers. So I think I'd prefer to eradicate it and keep an eye on the esophagus, and if I see something early, get in there and ablate it before it becomes something nasty. I don't have the answer, but it's sort of a balance of risks, and we're playing the odds a little bit, but that's sort of what makes sense to me.
Sure. Thank you, Wendy. I can make one quick comment, which is the Society of GI in the US has put a position statement identifying patients who are practitioners who live in endemic areas like the Mediterranean, Italy. These places, they should eradicate H. pylori even if it's asymptomatic, while physicians who work in areas like the US where the incidence of H. pylori is low, they should leave it alone and not even biopsy for it if the indication was not dyspepsia. So next question to Ricardo, and I want to thank the people for putting the questions. From Jack Timpins again, thank you, Jack, for your second question, and greetings to you. Do you use CO2 insufflation when you do endoscopy, Ricardo?
I don't do endoscopy, so I don't know. I don't know what the gastroenterologists use to insufflate the stomach, Jacques. I'm sorry, I don't know.
So does anyone in the group uses CO2 insufflation when they do endoscopy? Okay, Wendy does and Rachel does. Is that for intraoperative endoscopy or for endoscopy in general?
All of it, because it's a bit more comfortable for the patient. So if it's available, I'll use it.
Interesting. So Humberto Jimenez said, Rachel, that he thanks you for answering his question, and the reason he asked is because South America has a very high prevalence of gastric cancer. Now, I have a question about Rachel doing endoscopy after sleeve gastrectomy. Now, in the U.S., again, it's not easy to regularly scope patients. And we now know that the incidence of de novo GERD is 59%. The incidence of Barrett's is anywhere from 8 to 18%, 8% in the last systematic meta-analysis rather. But many of these patients are asymptomatic. So what's your strategy and what's your recommendation for scoping patients after sleeve gastrectomy?
So this is the part of the position statement that I have the most trouble with, and I know that the society's plan is to revisit this and rewrite, as more data becomes available. And I'm very eager for more data about this to help justify the screening recommendations that are in this position paper, because as of right now, I'm not going to be able to get asymptomatic screening approved, I don't think, on the data that's available. I'm as worried about Barrett's development as everyone else is, and I would relish the opportunity to screen as often as this paper recommends, but I'm going to have trouble implementing that in my practice.
And I think if I can make a quick comment, this is one of the reasons surgeons in the US have been very skeptical about the Barrett's incidence that is coming up in the literature in Europe. We're only allowed to scope symptomatic patients, and we looked at all the sleeves we've done in the last 10 years, and the incidence of Barrett's in symptomatic patients is only 2%. All of them we had preoperative endoscopy. So the question is, are we missing another 6% that are asymptomatic? I mean, no one knows. We scoped only 6% of the population, so it's really unknown. So Kamal, you mentioned earlier that you disagree with all these authors about post-op one anastomosis gastric bypass. So I need you to duke it out with Wendy. Why do you disagree? What do you think?
So, Abdurrahman, this is only a scientific disagreement. I hugely respect every single member of the team. Having said that, this is a position statement which does not grade the evidence and does not grade the levels of recommendation. So we have to take it as the way it is. So when it comes to the post-operative recommendations, as I said earlier, with regards to OEGB, the hypothesis itself is incorrect, let alone the evidence. Now coming to sleeve gastrectomy, which is again an important point, I wish to highlight one important thing there. Every single study that you will look at, even historical, the 3 studies that are quoted in this paper and ones in the future, will always find a 10 to 20% intestinal metaplasia stroke Barrett's esophagus rates. Why? Because we know that cardiac mucosa intestinal metaplasia rate is approximately 10 to 15%, and we know that the cardia migrates into the chest after sleeve gastrectomy. So a study that would need to be designed to adequately study Barrett's esophagus after sleeve gastrectomy would need to be mindful of this, that the cardiac migration takes place. And if you're going to study cardiac mucosa, which now appears to be lower esophageal mucosa, you're going to always find 15 to 20% intestinal metaplasia. So I think we'll need to be very careful with regards to that data. And otherwise, what we might end up doing, we might be doing over surveillance. And let's not forget, OGD is an invasive test, which when I used to read textbooks had a 1 in 25,000 mortality. It is not risk-free. It is not cost-free either. So I think we have to balance this in judgment, and that is why I agree wholeheartedly with all the recommendations except recommendation 4 of the task force. Politely and with all the respect that I can show to my esteemed colleagues in the paper.
So I guess you've got to remember this is being written by an international society for an audience around the world. It is going to be conservative. And we did grade the data and it was all very poor. So that's acknowledged that this is poor data, very highly prone to bias. This is exactly why we need a position statement. And so therefore an international society is going to put patient safety first, and they're going to give guidance that errs on the side of conservatism. And so that's why we've erred on the side of conservatism with Barrett's. There will be a Barrett's position statement coming out and delving more deeply into the Barrett's data, and probably not surprisingly, I guess, but the recommendation that will come out for surveillance is very similar. So I appreciate that this provides challenges around the world, but maybe it also provides some ammunition if you go to your insurers or if you go to your governance bodies and say, well, look, an international organisation is recommending that I can do this for my patient. It makes it a bit harder for them to withhold care. But all this really does, I think, is puts a plea out there. We need to collect our data properly. We need to be getting people to do prospective studies, enrolling their patients in their registries, and making sure that we get our patients back and we look after them well, and we document what we find so that we can learn and we can actually come up with some robust recommendations into the future.
Well said, Wendy, and thank you for giving us an insight into the Barrett's esophagus position statement. And I'm going to give you a final comment, Kamal, in just a minute, but I want to have Haitham comment about his practice of post-operative endoscopy after bariatric surgery and sleeve and one anastomosis gastric bypass in particular.
Now I changed my practice after the articles published by Jinko, by Rugger about the issue of Barrett's esophagus. Although I believe that the pathology is different, we have a lot of Barrett's. But I would like to second a bit Kamal in what he's saying. I see some bias in the final recommendations, and I was happy to read that they mention in the article that the position statement is not without bias, and I feel it in the recommendations because I think that all bariatric surgeries are refluxogenic in a way or another. I believe in having a screening endoscopy. Probably 1 year is too early, at 2, 3, or 4 years for all bariatric surgery. So they put exceptions for no OI gastric bypass and adjustable gastric band. They said they don't have data to support symptoms to findings. But Rich, let me just say it in her presentation now that patients who are symptomatic, they had less symptoms from asymptomatic patients So you cannot say to patient who had row gastric bypass, if you have symptoms after 5 years, come and do endoscopy. I believe it would be more reasonable to say that all bariatric surgery should have screening endoscopy 2, 3, or 4 years after.
I think you reinforce an important point, Haitham, which is the position statement clearly in endoscopy after bariatric surgery differentiated between sleeve and one anastomosis versus band and bypass. So I think it's an important distinction. So before we conclude, I would like to hear final comments from each one of you. Wendy.
I think a position statement is there to fill in a knowledge gap, and it's where we need guidance for practice. It's not to mandate what you should do. It's partly to make you think about what you should do, and it's to set down what an international society that's representing a global community thinks is reasonable and safe. So it should be a starting point for your own practices, and at the end of the day, you need to adapt that for what works in your local environment. But at the end, I think I would just, again, encourage people to gather the data, and hopefully in 2 years' time, when we look to revisit this position statement, we'll be in a better position to come up with some more practical and pragmatic guidance.
Well said, and thank you for leading the effort of this position statement and leading the Ifso registry committee currently. Ricardo.
Actually, I do agree with Wendy. We needed a position statement where there's a gap of knowledge. There's no evidence at all. So we needed some light at the end of the tunnel to start guiding practices all over the world. And of course, to adapt it to the local conditions, to the payers, to the prevalence of H. pylori, etc. So I think it's much needed. Wendy's a hard worker, and thank you very much for the opportunity to be here in this session.
Thank you, Ricardo. Rachel?
I also wanted to thank Dr. Brown and the authors and the task force members that are listed in the paper for all their work they've done on behalf of all of us. It's a great start. It's gotten everybody thinking. I hope that in the sound of my voice, there's some researchers that are inspired to fill the gaps that we have in our knowledge base, and that when we talk about it again with the revision as more data comes in, that this will get closer and closer to international consensus about how to look after our patients, which is everyone's top priority.
Thank you, Rachel. Kamal?
I echo everybody's comments there, Abdulrahman. I think the team has done a stellar job of producing a great document. My only watch out would be for the revision of this document would be that there are two sides to every debate. And in this document, there's no mention of the cost and the adverse consequences of the OGD itself. I think we should evaluate that as well, because from the patient safety point of view too, the OGD is not a risk-free intervention, and I think we need to evaluate the pros and cons of it in more detail. But thank you. It's a great document, and thank you for having me.
Well stated. Haitham?
Again, I acknowledge the work of Wendy and great work, but taking from 18,000 articles, 63, and do the analysis, but the fact that it is a retrospective data, as you mentioned, a low high quality data, and overall risk bias. This probably make the position statement a bit. We should review it as mentioned in every 2 years. But again, I've learned from it. I will do my pre-op endoscopy for symptomatic patients, so I will take it, and I will do my post-op screening for all my patients after 2 years.
Thank you, Haitham, and I want to thank all the listeners who connected with us today and asked us questions. I want to thank Manuela for putting this together, Dr. Ahmed Bashir for asking me, the chair of our communication committee, to moderate it, and I want to ask all of you, Wendy, Ricardo, Rachel, Kamal, and Haitham, only at Ifso you could connect with surgeons from Melbourne, Sao Paulo, New Orleans, Sunderland, and Beirut, and Charlotte, like this. Thank you very much and have a great day.
Thank you.